Sleep apnea has been known as a much frequent problem in patients with renal disease since the studies in the late 80s by Paul Kimmel. The phenotype of sleep apnea can be easily identified on the basis of polysomnographic studies. Among the polysomnographic traces, we have two critical traces: the thoracic cage excursion and oxygen saturation. In central sleep apnea, there is no neural drive to the respiratory cage, and then an apnea episodes. And simultaneous with this change, oxygen saturation goes down, hypoxemia. In contrast, in obstructive apnea, there is a huge respiratory effort against an obstructed airway. You see, there is an amplification of the excursion of the thoracic cage, and simultaneous with this, a fall in oxygen saturation. In the general population, sleep apnea is much frequent, 39% in women and 10–17% in men. Sleep apnea is recognized as an important risk factor for death and stroke in the general population. This is a time-honored study made 15 years ago where it was clear that people with obstructive sleep apnea had a risk of death and stroke much higher than controls without sleep apnea. But let's see how sleep apnea generates a high cardiovascular risk. An apneic episode is a stop in the respiratory airflow. With this stop, there is a fall in oxygen saturation and a marked increase in sympathetic burst, which is the physiological response to hypoxemia. The increase in sympathetic activity raises arterial pressure, and hypertension, particularly nocturnal hypertension, generates left ventricular hypertrophy, which in turn are a predisposing factor for arrhythmias. Therefore, the chain of events triggering high cardiovascular events starts from sympathetic activity and ends in hypertension, left ventricular hypertrophy, and arrhythmias. The prevalence of sleep apnea in the general population is 9%, and in stage 1-3 CKD patients is 3 times higher, 27%, to reach the 57% in end-stage kidney disease patients, a figure 6 times higher than in the general population. CKD is tantamount of sodium retention, edema, but edema is not only in the leg, edema is everywhere. During nighttime, edema is in the pharynx and the hypopharynx, and this edema restricts the airway and causes snoring, apneic episodes, hypoxemia, which in turn is a potent sympathetic activator. This activation is maintained beyond the night hours and causes not only nocturnal hypertension, but also systemic hypertension over the 24 hours. We have solid evidence that fluid retention is central for sleep apnea in dialysis patients. A classical study by Andreas Speratos and co-workers 20 years ago demonstrated that nocturnal hemodialysis, which allows a gentle fluid subtraction, associates with a marked improvement in the apnea-hypopnea index. And the same results were obtained by Sidney Tang, who compared CKD with nocturnal cycler-assisted peritoneal dialysis. Both this intensive treatment, which allow a better control of fluid overload, associate with a marked improvement in sleep apnea. I remarked that sleep apnea has a high 57% prevalence in end-stage kidney disease. In this population, sleep apnea is not only prevalent, but is also associated with fatal and non-fatal cardiovascular events and with shorter survival. Indeed, as compared to those who have a normal oxygen saturation, those who have a low oxygen saturation have a much shorter cardiovascular events-free survival and a much shorter overall survival. Results of these two studies, which were made 10 and 20 years ago, have been recently confirmed in a much larger study published early on this year. CPAP is the golden standard treatment of sleep apnea. But the effect of this treatment in patients with CKD has been little studied. We have just a limited amount of information, and this information derives from a big clinical trial performed in over 2,000 patients with sleep apnea in the general population, which were randomized to CPAP and usual care. Among these patients, there were just 12 patients with GFR less than 60 milliliters per minute that were treated with CPAP, and 10 which were treated with usual care. So it's a sub-study based on very small numbers. And in this study, one outcome measure, a secondary outcome measure, was the rate of fall of the GFR over time. And as you can see, the rate of GFR over time in these two small groups was almost identical, as it was identical the evolution of the albumin-creatinine ratio over time. Both results were largely non-significant, so there are no signals that treatment of sleep apnea may slow the rate of renal function loss over time. The lack of knowledge about the effects of CPAP in CKD extends to cardiovascular disease. As a matter of fact, we have no randomized clinical trial that tested the effect of this treatment on death and cardiovascular outcome in CKD and in end-stage kidney disease patients. Overall, it remains unknown whether CPAP application may improve clinical outcomes in CKD and in end-stage kidney disease patients. Renal transplantation appears to be the ideal therapy for sleep apnea because it corrects fluid overload and also abrogates the effects of uremic toxicity. In a survey made in 2009, where patients were divided according to the severity of sleep apnea, mild and moderate to severe, and were separated according to gender, man and woman, and matched for BMI, age, and sex. The prevalence of sleep apnea was identical in patients, the Greek columns, and in persons in the general population. Therefore, this survey suggested that renal transplantation may completely reverse sleep apnea. Beyond the survey we have just discussed, the positive evidence that renal transplantation reverses sleep apnea came early on this year in a paper published in the American Journal of Transplantation. Indeed, the authors of this study documented that a high hypopnea apnea index is substantially ameliorated post-transplantation. And even more interesting was the observation that the improvement in the hypopnea index went along with a reduction in fluid overload. The greater the fall in fluid overload, the greater the improvement in sleep apnea. We know that renal transplantation improves sleep apnea. This is nicely demonstrated. But there are still important questions on the table. First, which is the longitudinal evolution of sleep apnea after kidney grafting? Is the improvement after transplantation stable over time or not? And second, which is the longitudinal relationship between sleep apnea and blood pressure? Blood pressure as measured by the golden standard measurement, that is ambulatory blood pressure monitoring. We investigated these two problems in a cohort of 221 renal transplant patients. We did over 400 polysonographic recording and simultaneous ambulatory blood pressure monitoring recordings over 3 years in this population. And the results were published in June in the Journal of Clinical Medicine and the same month in the Journal of the American Heart Association. Let's see the evolution of the apnea-hypopnea index over time in renal transplant patients. After the baseline measurements where the apnea-hypopnea index was normal, the same index worsened after 1 and 2 years after the second and the third visit. Therefore, it's clear that after the early post-transplantation improvement, sleep apnea worsened over time. And the factor that go along with the worsening of sleep apnea post-transplantation are the male gender, a high BMI, and the older age. That is the same risk factors that are known to be responsible for sleep apnea in the general population. Let's move to the second study, the relationship between ambulatory blood pressure monitoring and sleep apnea over time. At baseline, when we separate subjects according to the severity of sleep apnea, no, mild, moderate sleep apnea, baseline 24-hour systolic blood pressure and baseline nighttime systolic blood pressure went along with the severity of sleep apnea. There was a sort of dose-response relationship between systolic pressure and the severity of sleep apnea. Therefore, these cross-sectional data show a progressive rise in systolic ambulatory blood pressure monitoring across sleep apnea categories of increasing severities. These patients had follow-up. Exactly, we were able to follow up 139 patients with repeated measurements of sleep apnea and ambulatory blood pressure monitoring. And in 99, the sleep apnea was stable, while in 40 patients it worsened. Let's look at these results separately. The 99 patients with stable apnea-hypopnea index. Across visits, as you see, there was no change in systolic ambulatory blood pressure, nor in nighttime systolic blood pressure. So stable apnea-hypopnea index, stable blood pressure. Let's see the 40 patients in whom the apnea-hypopnea index worsened. Here the results were different. In these patients, at the last visit, 24-hour systolic pressure went up, and in parallel also nighttime systolic blood pressure went up. Therefore, this longitudinal analysis confirmed the cross-sectional data showing an independent association between the worsening of sleep apnea and the simultaneous increase in 24-hour and nighttime systolic blood. We discussed blood pressure, but we should be aware that blood pressure is a surrogate endpoint. What matters are clinical events. And until now, there is little evidence that sleep apnea in renal transplant patients predicts clinical outcomes of importance, like graft loss or death or cardiovascular events. We have very few studies. Last year, Lubas and co-workers published a paper associating sleep apnea with transplant outcomes. And the follow-up was very long, over 20 years. But the results of this study were inconclusive because sleep apnea predicted a paradoxically reduced risk of death during the first 10 years and an increased risk in the second 10 years. There are also two additional studies. The second of these two was again published last year. And these studies were unable to associate sleep apnea post-transplantation to clinical outcomes. But these two studies are weak because the diagnosis of sleep apnea was made before renal transplantation in most patients, including in these two studies. Therefore, we sorely need better study to assess the link between sleep apnea and clinical outcomes in renal transplant patients. Let's summarize and conclude. Sleep apnea predicts cardiovascular risk in the general population, in CKD, and in dialysis patients. Fluid overload is the main causal risk factor underlying sleep apnea in CKD and in end-stage kidney disease patients. And this is important because fluid overload is a modifiable risk factor. CPAP reverses sleep apnea, but there is no solid evidence that these may mitigate cardiovascular and renal risk in CKD and in end-stage kidney disease patients. Renal transplantation improves sleep apnea. However, this treatment does not stabilize the disturbance, which gradually re-emerges over longitudinal observation. The rise in BMI and fluid overload underline the re-emergence of sleep apnea after transplantation. Sleep apnea, a potentially modifiable risk factor, is the main determinant of nocturnal hypertension in renal transplant patients. Thank you for your attention.